I'll be very brief. I want to introduce Dr. Noakes. Dr. Noakes, you've heard me talk. You're probably tired of me talking about the iTeach program that we had, and it was so glorious, and all this fun we had as faculty, and all the events we did. Well, Dr. Noakes was one of the principals who wrote the actual grant with the School of Medicine at Weill Cornell that got us the money. And you know, it was really through their insight, long before I even met formally for this program, although I knew Dr. Noakes before that, that they got the initiative going. I get to celebrate all the excitement of having participated, but I didn't have to do, you know, the original digging of the foundation and the work that got to the point. And I can't even tell you the number of hours that Dr. Noakes and those colleagues put in to getting a grant written, submitted, and funded. On top of that, she's been a great colleague to work with. She's helped dispel many of the myths I held about nurses in a very favorable direction. So it's really, with no further ado, I'd like to welcome to my friend, my colleague, and my upstate neighbor, although we still haven't bumped into each other upstate, Dr. Kathleen Noakes.
You have 14 snow?
I was telling my other class, I shoveled like 3.5 feet of snow last week up there. I love it, but I'm a bit sick.
So I'm being taped. So I was just going to sit, make it very casual, but I'm being taped.
It's okay. You want to say? You can say.
Yeah. Well, I wanted to sit late anyway. So you have the readings, you have the discussion questions. So we'll get to that. But I wanted to talk a little bit about myself and. Been a nurse in 1967, I'm sure way before many of you were born, which is nice. Really have worked on an interprofessional team since '83, first with oncology patients, cancer patients, and then clearly with people with HIV. So my clinical area is HIV/AIDS, and I've been doing that and did that forever. Lastly, working at a food program called Momentum AIDS Project, which does have a setting. It's a St. Cecilia's Church, which I think is on 106th and Lexington. So I come from an interprofessional education framework as you just can't survive as an individual because the patient is harmed. And I think if you really kind of keep that in mind, that you're not doing it for yourself or your discipline, you're doing it for the patient. And the patient could be your family member, could be you. So what's happened, we had a first spin of IPE work done in the where was I? I was at downstate. So I would say in the late 1970s, the early 80s, and there was a bunch of flurry, and they were basically courses on ethics and stuff, and then they went away. Because the big problem with IPE is it goes away when there's no external funding. This wave, the Macy Foundation by Macy's, is really kind of committed to the idea of IPE, and I hope it continues. I'm not exactly like, oh yeah, it's going to continue. The major barrier is the structural issues. It's not that the faculties don't want to work together, and it's not that the students don't want to work together. It's scheduling. And that sounds pretty obvious, but that's really what the major problem is. You have your curriculum, we have our curriculum, medicine has their curriculum. We figured out, by the way, of all of the curriculums, medicine is the most flexible because they own the students. They basically, once you go into medical school, you're owned until I think they spew you out. And you hear from Byron and I think maybe Joe, and those are the physicians that we work with, and really cool people. But the other curriculums are coursework and outcomes and grading, and so it'll be interesting. But the bottom line is that the patient will benefit, we believe, from a communication across disciplines. So do you have any questions you want to ask me before I kind of get into some content on, and the content I know is a little dry.
I have a question.
Sure.
When, in your experience in the field working with social workers especially, what have you
I
found?
knew you were going to ask me that.
Well,
And I have an answer.
oh, good.
And I'll answer it from the point of view of relational coordination. Okay, so you have a theoretical answer. And it's communication. What I find is social workers are very interested in getting information, but they don't communicate back. And so if I was going to challenge, think about how do you communicate back what your findings are to the other members of the team. So how much detail do you need to communicate back? Not that much. You know, and I think that's one of the issues, that you folks drill very deeply down into social support, the social networks, and you've got an incredible amount of information. I don't really need to know that as a nurse. I just need to know, basically, that you've investigated certain things, and I'll give you a concrete example, so that I can have some confidence that I can discharge the patient. But I really need to know that information to come back to me with, I talked to the daughter, so let's take the situation of a person who is going home, they live alone, they have a fractured hip, they're coming to physical therapy. I've referred that person to you to investigate the home situation, to investigate safety. I need to hear back from you. What did you find? Are there steps? Who's going to deal with the steps? Is there food issues? I need that information back. So I know you're doing it. I don't have any question that you're finding all this good stuff out, but you need to communicate back to me. And one of the big issues of the electronic health record in a hospital situation is, rather than somehow or another creating more communication, it seems to be creating more silos. In which, I think with a paper record, if it opened up and all of a sudden didn't open up to your color charting, maybe you would read it. But with the computer, it seems to not. So that would be, if I was to say anything, if you're getting a referral, especially if it comes from a nurse, telling the doctor is really annoying. Okay? It's really frustrating and annoying. Because I told you, you're responding to the doctor. What's wrong with that? I respect you. Tell me back. But you don't need to get me a lot. Because when I push back this way, I get, well, confidential, blah, blah, blah. I don't need to know a lot. I just need to know, is the person safe? And, if you tell me the person's safe to go home, I trust you. You're my colleague. Because if the shit hits the fan, social worker told me that they assess the person and they're safe to go home. And that's what I'm documenting. Okay? So from a team point of view, we're all in this together, because if we end up in a malpractice suit, we all end in this together. Because I'm documenting that. So that would be my one thing, that the communication has to be, if you get a referral, you got to get back. If you ask the nurse for something, obviously she's got to, or he's got to get back to you also. And there are different languages. There are definitely different languages. You kind of lean more towards the language of patient empowerment and free decision making. we kind of lean more to the language of, if you do that, that's really cool, but you're going to end up back in the hospital. You know, so it's kind of, it's a different sort of, you know, sure do people have the right to refuse medication? Sure they do. But are they willing to take the consequences of refusing medications? You know, and, oh yes, no problem, I'm not going to take my pill. Now they're in the ICU. I mean, this happens all the time with HIV. I'm not taking ART, especially when it was much more complicated. I'm not taking antiretroviral drugs. Those drugs kill people. They're genocide. They're the white people trying to wipe blah, 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 blah. Now you're in the ICU and you're intubated. You've got a tube down your throat because you can't breathe. Because your immune system is so depressed that you've got PCP pneumonia. Is that really what you wanted to sign up for? So, you know, that's kind of, I think that creates a bit of a tension because we see what happens when people don't. And there is a point in which you just walk away. You just say, you're an adult, you're competent, you can make your own decisions. And you try to keep the person engaged enough somehow that they don't end up in the ICU intubated, but they end up just in the emergency room with PCP, and then we treat them and then they go home. So you try to, you don't reject people, but on the other hand, sometimes we just can do what we can do. And nurses are kind of, to use the relational coordination, are probably more boundary spanners in which we're supposed to know a little bit about a lot of things, and we're supposed to be able to translate for the patient what the doctor is saying within the legal issues, which is a real joy. Yeah, that's kind of, those are blurred a lot. We have Kyle here from Japan, who's a doctoral nursing student. And, you know, if you want to see what it was like in the United States 20 years ago, go to Japan, because, you know, the family says, don't tell my mother she's got cancer, and the doctor says, okay, right? Right, today. So there's the woman dying from cancer, but the family doesn't want her to know. And the doctor's good to go with that, because he doesn't really want to tell her anyway. So we're respecting the culture of Japanese, because the family says don't tell. And the family, you know, the patient, so it's a lot of secrets, which are really exhausting. They kind of exhaust everyone. They exhaust the patient, because the patient will come then to the nurse or the social worker and say, don't upset my family. So what I would do in that kind of a situation is try to, you know, talk to the daughter. You know, do you really think your mother doesn't know? No, she doesn't know. Have you asked her what she thinks is wrong with her? No. Well, you might want to ask her. Anybody else in the family die from this kind of cancer? Well, her brother did. Well, don't you think she kind of maybe, you know, like, so it's kind of that breaking down of denial. And then basically, when they totally collapse emotionally, we refer them to the social worker. And then you can piece them all back together again. Yeah. So questions, comments, yeah.
I actually have a question, because I really like the idea of the boundary spanner.
Yeah.
Because I find that I sort of do that naturally a little bit, or maybe social workers feel that way because they re-communicate things, I would hope. Apparently not, from what you're saying.
Well, no, I didn't say you don't communicate. I said you could communicate more.
Better, yeah.
Or
so,
more.
And so in terms of the boundary spanner, I'm sure you'll talk about this, but
Don't count on that.
what roles does that entail in terms of like meetings? They say that that's sometimes unproductive and how that can be made better? And also, why do nurses have the boundary span or role necessary? Like, why nurses might have that more as opposed to social workers?
Right, because we speak the medical language.
Yeah.
We speak the medical language. So when somebody says, now that's not to say, okay, that's not to say if you're a social worker on an oncology team, you don't learn that language, okay, or on an HIV team, but typically nursing and medicine are looking at two sides of the same issue, the pathology typically. So we look at it, we would say, we look at it from a caring perspective, and medicine looks at it from a curing perspective. Whereas you're looking at a lot, you're not looking, we focus typically on the individual. And our individual is typically a sick person. You focus much more on the individual in a family and environmental setting. Okay, so that, yeah, the person has HIV, but ARTs or antiretrovirals are important, but what about the child, you know, that kind of thing. So you bring to the table much more of a richer picture of the sick person. So let me just make sure I answered it. So when a physician says stage 4 metastatic, I know exactly what that means. I know what treatment's not going to be offered. I know what the prognosis is. I know what kind of support services I got to put in. And all the physician said was stage 4 metastatic. Okay, so it's a shorthand for me. And there are shorthands that we've developed that really convey, you know, a pretty big challenge, you know, piece of really negative information. You know, I had a client when I did oncology. I'll never forget this poor guy. He had 18 sites of metastasis. And he said to me, "Is that a lot?" And I said, "It would be better if you had less than that." You know, he was going to die. So it's just in these meetings, the social worker might say, "Well, have you thought about chemotherapy, or have you thought about surgery?" And I know, because it's stage 4 metastatic, those aren't options. Okay, we're never going to operate on stage 4 metastatic because if there are 18 metastatic places, you got it. So it's, you might kind of ask a question during the meeting that, until you learn the language, that might make total sense to you. You've read about, you know, cancer, surgery, chemotherapy, radiation therapy, blah, blah, blah. All of a sudden, we're talking about hospice. And you're like, doesn't this person have a right to blah, that kind of thing?
Yeah, I just wanted to make the point because it ties into the assigned readings for your practice lab this week, which was the Okamoto article, which spoke about interagency collaboration. And the two constructs that Okamoto writes to, is communication and fear. And what Dr. Noakes is speaking about, and in our small group we spoke about it, language is so critical. And if we're going to collaborate, whether it's a discipline or another agency, if we don't know their language, there's so much that gets lost in translation that we end up having to spend time that we wouldn't ordinarily have to spend. The other construct is fear. And the fear of that other discipline, that other professional, that other agency has in terms of you usurping their authority or creating a friction that might not need to exist, or of introducing a concept to a patient such as, well, have you considered chemo, when in fact that's not something that they may need to have added.
Yeah.
You know, so the fear of introducing things that you don't understand enough about. So I think there's that article actually has some resonance for what we're talking about right here.
Yeah, if you go in and you talk to, if the person's stage 4 metastatic and you start talking to them about chemotherapy as an option, and we know it's not an option. Now why wouldn't it be an option? Because there's so much bulk tumor there that you really, chemo's not going to work, okay? Radiation may work. So now we've got this person who's now hopeful that they can get chemo. And they know that chemo is associated with remission. So now we've got to unpack and now the person feels like we're withholding chemo because they're black, purple, green, old, young, God knows why we're withholding it. And it's a lot to reconstruct. So, but that's kind of why the meetings, the case meetings, the huddles, in which everyone feels comfortable saying, why not chemo? Why aren't you doing chemo for this person? Oh, because the tumor is, just blah, 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 is really essential, and will really, again, help the patient a whole lot. And that we're all kind of on the same page with what's available for the person. Other questions?
I have a question.
Sure.
Taking from what Professor Morano was just referring to, unnecessary friction between practitioners. And,
Let me just stop you. You notice how it's unnecessary friction, okay? So you have to all acknowledge we will have friction, okay? When you walk into a room, you have to acknowledge that there will be friction. And what you're asking about now, and I'll let you finish, is what's unnecessary friction.
right, and avoiding that. And so, and speaking of the team meetings or the huddles, as you just called it, it seems like that would be a prime opportunity for the team to, which is like we do with our clients, try to establish a safe rapport so everyone's voice is heard, and so each team member feels validated, even if there's disagreements. So then when the huddle breaks and you're out there, it seems like that could be a really powerful team building moment, not only information sharing, but it seems like without that, or without that done well, it could create unnecessary friction.
Yeah. The issue is time. And so what you end up doing, so like at Momentum, we would have team projects we'd have huddles or meetings at the end of each. And I learned pretty quickly which issues I wanted to bring to the team. And because everybody's sitting there, it's 6:45, gotta go, gotta get my child, gotta blah, 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 blah. In a hospital situation, gotta go to the operating room, gotta it's chaos, it's organized chaos. So one of the things is you really start to figure out what can you get from the team, and then you find out who your allies are. Like after the team member, why you go to somebody who you trust, and you say, why didn't they offer her chemo? And I think the other thing is you give the team probably a lot longer than you would expect, probably a month or two, to really acclimate yourself to the team. And then all of a sudden it's like, oh, okay, they're doing it that way. Yeah. That it's not, it's being in a hospital situation, in a setting, you're really on a moving train, almost the Acela. Because there's not a lot of time to discuss, we're moving. So you get very clear. You may want to give all this information, but they don't want to hear it. They just want to know is the person safe to go home. And then if you have a piece of information, the person's not safe because the grandson is dealing drugs out of the apartment, that's the piece you give. So I think, they'll talk about, I think it's a SWOT analysis or something, that we really teach people how to communicate in a timely kind of, I think it's SWOT, which is situation or something or another, or whatever. But there's these little things in which you just kind of give the information. So I'll give you a concrete example of what we teach the nurses. So they're in the home care setting, and they pick up the phone, and hi, Dr. Jones, I'm the visiting nurse. I'm here visiting Mrs. Jones. She feels really well, but her blood pressure is. Way too many words. Way too many words. Hi, Dr. Jones, I'm the visiting nurse. Mrs. Smith's home, blood pressure 200 over 180. No, 200 over 100. She'd be dead if it was over 180. 200 over 100. Took the Lasix earlier today. Gained 5 pounds. What do you want me to do? Okay? It's just fact, 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 fact. That fact tells the receiver that that person's going into congestive heart failure. Okay? From those pieces of information, if the doctor's got any, God bless you, if the doctor's got any smarts, the doctor knows that the answer the nurse is looking for is give her another Lasix and come back tomorrow. So if the doctor doesn't give you that information, then you keep pushing. You know, she's got into congestive heart failure before, so you kind of give a little bit more information. And literally, with the Momentum clients, they would say to me, I don't understand this. And you know, Momentum is a food program for people with HIV/AIDS, mainly drug users, you know, more of the marginalized folks. So they'd walk into an emergency room, and they'd blow them off. And then they'd come into the food program and meet with me, and I would write a note. And at the end of the note, I would say, rule out. And they'd take the note back to the same emergency room, and they would do something. And these drug-using, marginalized people would say, how come when I walked into the emergency room the first time, they told me everything was fine. When I walked back in with your note, which was written on a piece of paper, they did something. And I go, beats me, no clue. It's the information. You know, clearly, clients also ramble. I mean, one of the reasons why marginalized people don't get the kind of, I argue, don't get the kind of health care they need is they don't know how to use that 5 minutes with the provider. They're telling them way too much information. And all we need is what we need in order to do something. So it's the communication is key. It's really key. It's not lack of respect. It's just simply, you need to tell me what I need to know, when I need to know it. And you need to package it in a way that I can hear it. If you're new to an area, I expect you not to be able to package it in a way that I can hear it. But as time goes on, I expect you to package it in a way that you're giving the piece of the puzzle that will impact on the client. Question? No? Comment? You sure? Mm-hmm. Okay. Questions, comments, pushback? You could ask me, do I use Dr. Noakes with clients? I do not. I do not. I'm the nurse. So that's because it really confuses them. You know, it really, and that's one of the things with the DNP and the nurses, with the doctorate, and it's really going to confuse them even further. You know, who is my doctor? And so, like, you will get a lot of clients who are seen by nurse practitioners who say, my doctor is. You can think about correcting the patient. That's fine to say, well, your doctor is a nurse practitioner. But I'll lay odds, they'll say, yep, that's my doctor. And so that's why sometimes the nurse practitioners kind of give up. You know, in which, you know, having the client somehow or another feels good about calling their healthcare provider a doctor. It just somehow or another, you know, they know they're a nurse practitioner, Because when you say, well, do you know that Susan's a nurse? Oh yeah, I know she's a nurse practitioner. Yeah, she's my doctor. She takes care of me. You give up. They're informed. It's not like you're, you know, maybe you have the name on. Yeah.
Do you all know the difference of the different levels of nurse and nursing in general? Because you're hearing acronyms, and I want to make sure
Right.
you're all on the same page. I see some saying yes and some saying no. So
Okay.
would you mind just, because that,
Yeah, no problem.
I know you have relational coordination on the mind, but here's a mark.
Right. Yeah, this is a pen. I don't think I'm going to do that.
Yeah, we're forever messing with our whiteboards.
Yeah.
There you go.
Thank you. Nursing is not particularly proud of where we are right now, okay? We would like to be somewhere else, but we're not. And we've been around for a long time. You know, Nightingale was the first person who's, 1860s, blah, blah. So right now there are 3 levels of licensure, and in New York State, but most places. And each state has a different, because health is not in the United States Constitution, it's in the state constitution. What you can do in New Jersey, you can't do in New York. So for example, as a nurse working in a hospice, I can declare a person dead in New Jersey, but I can't declare the same person dead in New York. Okay? Now, if you're working in a hospice, the purpose of a hospice is to provide quality of life before you die. All right? So this is not like dying is a surprise. So to declare a person dead who's in a program that's helping them until they die, you see what I'm going? So I'm not saying that nurses should declare, God forbid, any of you fall out right now. We do CPR for 5 hours, and I'm not saying I want to declare you dead, okay? You need a medical examiner, you need toxicology, you need all sorts of horrible things. But if you're in a hospice, so who cares? Who cares about this? Well, my partner's mother, 20 years ago, died in the Bronx, had been getting health care in Westchester. The body sat in the home for 8 hours because the Westchester medical examiner wouldn't talk to the Bronx medical examiner. So we sat with her body for 8 hours because no one would declare her dead. Okay, so it's kind of like so odd. It's very nice for a hospice nurse who's been coming into your home, taking care of you, taking care of the family, to say, okay, your mother is now dead, it's time to call the funeral parlor. Funeral director comes, takes the body, yada, yada, yada. Very seamless. And this happens a lot with cancer, the hospice people, what happens with cancer is, let's say, Dr. Smith is your primary doctor, okay? He's taking care of you for 20 years. But now you have cancer, and you've gone to Sloan. And Dr. Jones is taking care of you during the hospice time. You can't get Jones to declare you dead. Jones only wants to treat you. You haven't talked to Dr. Smith in a year. So how is the wife going to get Dr. Smith to declare, you see where we're going? So one of the things we want from a social worker is the death plan. You know, who's declaring? Where's the funeral parlor? Where's the will? Not the will. Where is the certificate for the grave, so that we can open the grave?
Place of interment,
yeah. And then who's paying? Because God forbid you die on a Friday evening. The funeral directors now want cash. They want credit cards, they want cash, they want whatever. So this all has to kind of be figured out. So to get back to where I was. So the law really impacts on practice in really silly sort of ways. So we have practical nurses who have to work under the supervision of a registered nurse. Now sometimes you get yourselves into agencies in which the agency is like, especially developmentally disabled people. The law is very interesting about this, but there's got to be a registered nurse somewhere, because that LPN cannot function independently. There has to be a registered nurse. There might be one registered nurse in the nursing home, and she's on during the day shift, but there's got to be somebody who's a registered nurse, because legally the registered nurse works under the supervision of the LPN works under the supervision of the registered nurse. Unfortunately, there are 3 ways to become a registered nurse, at least. You can have a 2-year degree, you can have a 4-year degree. Diploma schools are kind of gone. So a diploma would be like a hospital school, like St. Vincent's School of Nursing. We kind of closed them. So they don't really exist very much in New York. So a registered nurse could have 2 years community, could have 4 years baccalaureate. We all sit for the same state board for nursing. And let me try a different pen.
Yeah, they're all.
Right, I think we killed that one. Well, we're not doing too much better with this one. And we all take the same state board for nursing. So it's a national licensing exam that you can't call yourself a registered nurse unless you've passed this. What's happening is the marketplace is basically saying they don't want to hire 2-year graduates. Nursing has said, we don't want to educate 2-year graduates since at least 1965. Okay? Since around 1965, we have said that the preparation for registered nursing should be a baccalaureate. CUNY is one of the major producers of ADN registered nurses, probably in the country, maybe in the world. So, you know, it's a bit of a mess. So we're trying to do articulation, right? It goes on and on. So anyway, so the nurse you're working with, who's a registered nurse, may have 2 years in a community college, may have 4 years in a baccalaureate. You won't know. You won't know. Maybe you'll know. And our research is showing that there's definitely increased mortality associated with having an associate degree versus the baccalaureate. But the marketplace is what's fixing it. We haven't been able to fix it. So then the nurse practitioners are different licensed. So there's 3 levels of licensing. The nurse practitioners, and just to kind of be broad, have master's degrees in nursing. So they would be the same level as you folks in terms of education. So they have a master's degree. They can prescribe medications. They can diagnose. Right now in New York, they must work closely with a physician. We're trying to say that we don't need that. So we're trying to say we don't need practice agreements. We managed to prove that the care is equal or sometimes better when it's given by a nurse practitioner rather than a physician, which the physicians are really embracing. It's wonderful to listen to this, because what they're now saying is, how come it takes us 7 years to educate a physician who gives care as good as somebody that is, you know, a master's degree? What are we doing? So the answer is really the nurse practitioner takes care of routine issues, and the physician takes care of more specialty issues. And so the Affordable Care Act, nurses' answer to the Affordable Care Act is the nurse practitioner. You know, we kind of, and Hunter's got a pretty big program on that. So when somebody says, I'm a nurse, so for example, I had a diploma And then I got my bachelor's in nursing from Hunter, my master's in nursing from Teachers College, and then my PhD in nursing from NYU. But I wanted to teach, so I was on that trajectory. Just to muddle it up a little bit more, the nurse practitioner has a master's, and just so that you kind of know, that might be 600 clinical hours. And the DNP is a doctor of nursing practice, and that's 1,000 hours. Totally confused? I get confused. What time is it?
It is 1:15, so we have about 5 to 10 max,
Okay.
and if you want to go to the study guide questions.
Okay. So let's just to put this a little bit into a theoretical framework. Taking relational coordination is a theory. Okay? Because for me, theories are kind of like roadmaps. They're sort of a way in which you can kind of make sense of some things. It's not you're just in the middle of the forest and you don't know where the hell to go. So this person, Gittell, came up with this theory of relational coordination. And the reason why we used it for the IPE grant is that it talks about high intensity, high functioning institutions, which are what hospitals are. And talks about the work practices, the cross-functional selection, okay, the cross-functionality. So let's say that you're in a hospital situation and you know that this particular job should be done by the nurse, but there's no nurse in sight, or the nurse has 2 codes going on, like let's say get the woman some juice or something. So you do it. You know, it's a lot easier than he's listening to the bell, the bell, the bell. The conflict resolution is the interesting part, or one of the interesting parts. People do not like conflict. Women do not like conflict. Nurses don't like conflict at all. And nurses are very conflict-averse people. It's very, the older I get, the more I think that there are certain personality types that are attracted to certain professions. So when you are adverse to conflict, you don't want to engage in the conflict, you do a lot of avoidance. And I was just in Best Buy yesterday, and with my hair and my age, I can go into any electronics store and guarantee 15 to 20 minutes of no one talking to me. Absolutely no one engaging me, no one talking to me. The other place this happens is the shoe stores on 14th Street. The ageism is fantastic. So there's an avoidance, okay? But sometimes with this avoidance, it generates some anger and resentment. And then you have like the Nurse Ratched kind of person, in which they're just kind of like boiling over. So you have to kind of figure out how to get the team, how to create, as you said a little earlier, a safe situation where we can talk about the conflict, where we can talk about the idea that I just think we need to, we've got a situation here in which, I'm counting on you to do such and such and you're not getting to it, or you're not, that kind of thing. So the idea of relational coordination builds in the idea that we all as part of the team have to recognize there's going to be conflict, recognizing that the physicians basically will blow it away. No, we're all functioning just fine. My team, that's what they like to say. You'll hear it when they speak. My team is a high-functioning team. Have you asked them? Do they perceive themselves as high-functioning? Why would I ask? So, the idea of conflict resolution. Performance measurement, I think we can, we're looking at patient outcomes. We're looking at patient safety. The rewards, there's no question in anyone's mind that you don't get paid enough. And that's just the way it is, you know? When I went into nursing in 1967, we didn't get paid enough either, but we jumped up and down and unionized and kind of really acted out a lot, and now we get paid a decent salary. Now the nurses will tell you they don't get paid enough either, but you really don't get paid enough. So that's something you as a profession have to really think about. You know, it's nice to have the rewards of working with the marginalized and the underserved and the poor people, and it's light exhausting. So you might want to think about, as a group, thinking, you know, just thinking about salary, you know, and is an agency hiring 2 social workers and no one else because they feel like you can run around and, do you know what I'm saying? Have you looked at your salaries in comparison to nursing? Have you looked at your salaries in comparison to this 2-year graduate? Well, you should be getting a little annoyed if you haven't. Okay?
Thanks for stirring them up.
Your starting salary for a registered nurse with 2 years of education is probably in New York City worth about $55,000. You know, the nurse practitioners are making about $100,000, $110,000. My students are much richer than I am. You know, I feel absolutely no obligation, and literally, you know, I don't. They make a lot of money. I don't make that. Well, now at Hunter, finally, after being here 28 years. But yeah, there's money to be made here. Okay, so you need to think about the rewards. And it needs to be probably more than just feeling good. You know, what in particular would you value? The cross-functional meetings, you don't want to always be the minute taker. You want to rotate it, including having every member of the team, i.e. the doc, take the minutes. You know, because, and if you see you're on a team in which one person is always taking the minutes, one person is always organizing the food, one person, kind of say, hey, don't you think we should, like, you know, split this up a bit? Now, if the physician says, I don't have time to take the minutes, but I'll bring my secretary in to take the minutes, that works. Okay, so we don't need them to take the minutes themselves, but we need them to share the responsibilities of making the team work. So to rotate it a little bit. And then we talked a little bit about the boundary spanners. The idea that there's one patient, when you get into a clinical situation, you really have to immerse yourself in what are the other parameters that the other disciplines are dealing with this particular group of people. You know, if it's fractured hip people, or if it's, you need to kind of read that a little bit. You know, go Google it, care after a fractured hip. So at least you have a familiarity. Nobody expects you to be the expert in it, but like when I go to the AIDS conferences, the international AIDS conferences, they have these tracks on biological, okay, very, very microcellular level. If it's a 15-minute, you know, block, I might understand 3 minutes of what they're talking about. But I sit there and I listen, and every once in a while they'll say something that, oh, I can apply that to my clients. That makes sense to me. That makes sense to my practice. So you're reading out of your discipline, but you're kind of bringing it back into your discipline. So, you know, I did my homework because I had questions and all of that, but what else do you want to ask? Have you had experiences with nurses that you weren't quite sure how to handle? Are they all warm and fuzzy and Florence Nightingale? No. No. They're pretty direct people. They converse in a pretty direct way. Some of them can be pretty off-putting. There are 3.3 million of them. So it's hard to get 3.3 million of anything, to do anything. We were looking, Kayla and I were looking up yesterday, nursing is now 9.6% now, which I was surprised, because it had been more like 5%. What that tells you is the economy. We have more and more people coming into nursing. Part of it is this. A lot of times, a person will say, I want to be a nurse practitioner. They have no clue what that means, but they heard about it, and that's what they want to be. And you just say, yeah, okay, that's fine. We can't all be nurse practitioners. God bless you. Somebody's got to take care of people. Yeah.
Okay, so, because I know that they get cranky because they have a 2 o'clock class and some haven't eaten lunch yet.
Okay.
But,
we don't want any hypoglycemia.
No, we don't, although we have a nurse present.
We do.
I'm feeling quite relaxed right now.
Eat food.
But I want to thank you, Kathy, Dr. Noakes, for coming to speak. And I'm glad you went in the direction you did because we could have just done the relational coordination thing. But
Boring.
I think what we miss is we don't have the interaction with the other colleagues that we had with the iTeach program. And just hearing it from the other side certainly resonated for me, so I want to thank you on behalf of the class.